Hey, future respiratory therapist and respiratory therapist practicing now. I want to talk to you about this topic that sometimes I think tends to get overlooked. And it gets overlooked because so many times we get caught up in just, does our blood gas look good? And when you look at your blood gas, you're typically looking at really just a few items. Okay, so you have your pH, your PaCO2, your PaO2, and your bicarb. So you have a tendency to look at this and assess it, and you say, oh, everything looks good. So my pH is 7.40, my PaCO2 is 40, and my bicarb is 24, and you have a PaO2 of 95. So if you were to look at this blood gas, you would say everything is normal. And I would agree with you. But I want to challenge you today to take your blood gas interpretation skills one step further. And I'm going to ask that you start assessing also your hemoglobin. Now, the reason hemoglobin is important here is because hemoglobin and the amount of hemoglobin is a major player in the game of tissue oxygenation. Okay? And I think this is where sometimes we get confused, because what you need to understand about this is that while your pH and your CO2 and your bicarb are normal, but your PaO2 is also normal, what your blood gas is reflective of, specifically your PaO2, is your effectiveness, or it's more of a reflection of external respiration. So I want to erase this and I want to talk about this concept for just a second. So when you learned way back in school, probably in anatomy and physiology, you learned about the difference between external versus internal respirations, right? Now, the term respiration refers to gas exchange. And this is key because you have to understand that gas exchange happens at 2 points in the body. It happens, one, at the alveolar capillary membrane within the alveolar, to where the alveoli meet the pulmonary capillaries. That's one place where gas exchange happens. But then there's also gas exchange that happens at the level of the tissues, which is a result of metabolism. Okay, so the tissues, the cells, they take oxygen out of the arterial blood, they metabolize that oxygen, and the byproduct of that is carbon dioxide. Now, carbon dioxide re-enters the bloodstream, returns back to the heart via the inferior vena cava, the superior vena cava, back into the right side of the heart, and makes its way back to the pulmonary capillaries, where then that CO2 diffuses back into the alveoli to where it's ultimately exhaled, yet oxygen diffuses into that blood at the same time. So this is a difference. This is very, very important to understand. I forgot an N right here. External respiration versus internal. What do these terms mean? Well, external equals gas exchange. I'm just going to say gas X at the AC membrane. This is at the level of the alveoli, which is what a PaO2 is reflective of. Is there adequate oxygen getting from the from the alveoli into the pulmonary capillaries and into arterial circulation? Internal respiration is the gas exchange at the tissue level. So at the tissue level, you have tissues taking oxygen off and giving CO2 back into the blood. Now, this is important because when we think of what we do as respiratory therapists, a lot of times we get caught up in pH and PaO2. specifically P little AO2. But what our jobs really are as respiratory therapists is to make sure that the lungs are providing what's needed for the blood, and then the heart is making sure that that oxygen is getting out to the tissues. That's life. That's a human living, is aerobic metabolism happening at the level of the tissues. And so you want to understand and keep that concept. Come on, babe. Look, she's messing with me right now. She just walked in and here she goes messing me up. Anyways, what you want to be able to do is to understand the difference in these two. When you're making your ventilator changes, what are you looking for? Oh, our PaO2 is down. So what do we got to do? We got to get that PaO2 up. That's fantastic. But is that leading to an improvement of internal respirations? Maybe so, maybe not. Okay? That's what you have to ask yourself. And that's why I'm going to challenge you right now to consider evaluating your hemoglobin on every single patient that you ever take care of. And here's why. Okay? If you remember this formula, and if you've watched this channel for any period of time, you know that I'm always going to try to bring it back to a formula. So here's the formula that we're talking about now. CaO2. This is your total O2 content formula. Also sometimes referred to as your carrying capacity. Okay, so this is the number that gives you a reference into, are you getting enough oxygen to the tissues? So sure, you're getting enough oxygen into the arterial circulation, but are you getting enough oxygen delivered to your tissues? So this formula looks like this. Hemoglobin times 1.34 times your SaO2. We do all of that, and then we add that to PaO2 times 0.003. Now my goal in this video is for you to recognize how important this value is in regards to tissue oxygenation, how important this value is, and how minimal this value is. And when you grasp that concept, you will stop focusing so much on making sure that your P little AO2 is perfect. And you'll focus more on, do we have enough carrying capacity to get to the tissues? So that's where this video is going from here, okay? So this is the formula, hemoglobin times 1.34 times your saturation. You do all of that, and then you add that to P little AO2 times 0.003. Now, whatever number you have in your mind, if you multiply it times 0.003, you're going to get a very small number. Okay? So this portion of the formula, which we're going to see here in just a minute, is virtually not important. Okay? So keep that in mind as we move through the rest of this video. So if we take some numbers here, we're just going to go with what this looks like for a normal patient. Okay, so a normal male has, or a normal hemoglobin for varies for females and males, but typically 12 grams per deciliter up to 16.5 grams per deciliter for a male, as low as 12 for a female. That's pretty much your normal range for hemoglobin. Okay, now if we take a normal hemoglobin, let's just say 15, we multiply it times 1.34. We take a patient who is oxygenating, has a normal saturation, we get something like this. And then we add this to P little AO2, let's just go with 90, times 0.003. Let's see if we get a normal value, okay? Now, you know that the normal value for CaO2 should be between 16 and 22. Now, some places reference this at 17 to 20. It's okay. Small variance in references depending on normal values, depending on what reference you look at. It's okay. Those are still basically the same numbers. Everyone agree? Cool. So here we go. So we take out your calculator. and you're going to see that when we do calculator, 15 times 1.34 times 0.98 equals 19.7. And then we're going to add to that 90 times 0.003. And that gives us a much smaller number, 0.27. So when you add these together, you see you get 19.97. Now, before we even added this number to our value, you can see we already had a normal value. It's only going to go up from 19.7. So remember, normal, 16 to 22, if you're using 17 to 20, it doesn't matter. 19.7 is normal. And so this person, obviously, normal hemoglobin, normal saturation, normal PaO2, everything's going to be normal. But what if that's not the case? Let me give you a different scenario. Let me give you a patient that looks like this. And I'm going to erase the formula too because you should have it by now. First of all, if you're a second year student, maybe even a third semester student, this formula should be in your brain all the time. You should know it. You should know how to calculate it. You shouldn't have to look it up. This is a formula that you must know. So, if we take, let's say, a patient that comes in from a massive trauma with a ton of blood loss. Let's take a patient that comes in with a GI bleed and they're hypotensive and they're losing blood. You take this patient and you see you have very different values. Let's just say we have a hemoglobin of 8. We're going to multiply that times 1.34. And let's just say that our PaO2 is 120 and we have a sat of 100%. Okay? So your saturation is going to be 1.0. It's 100%, but when you turn that out of a percent into a decimal, you multiply it times 1, and then you're going to add 120 times 0.003. Now, let's talk about this for just a second. From an external respiration perspective, the lungs are doing their job. They are getting oxygen into arterial circulation. But let's break this formula down and see where we are from an internal respiration perspective. Because I feel like we're going to get a very different story when we get to that point, okay? So, if we do 8 times 1.34 times 1 equals 10.7. And then we're going to add to that what our arterial oxygenation is. This is the oxygen dissolved in plasma, is 120 times 0.003 equals a big whopping 0.36. So we add that to 10.7 and we get a carrying capacity of 11.06. Now, remember our normal values here. Before we ever even added the 0.36, which is a result of external respiration, the lungs' ability to get oxygen into the arterial circulation, because of our hemoglobin, we were already at a deficit. There was no way that you could multiply something by 0.003 and get this 10.7 up to 16 or 17. There's absolutely no way. It's impossible. And so that's what I'm trying to drive home right here, is that when you're talking about internal respiration, you're talking about tissue oxygenation, you have to understand the value and the importance of hemoglobin. Okay? Now, this patient has a carrying capacity of 11.06. You should not be surprised when you have this patient whose blood gas shows good oxygenation but shows a metabolic acidosis. Your job as a respiratory therapist is to understand that that metabolic acidosis is a result of the tissue hypoxia that's resulting from a decreased carrying capacity. You see, when there's not enough oxygen that gets to the tissues, then the tissues don't just die. They don't say, okay, well, if there's not an efficient level of internal respiration happening, then we'll just flip to anaerobic metabolism. So we'll go from aerobic metabolism, when we have oxygen to metabolize. If we don't have enough oxygen to metabolize, which in this case you wouldn't, then you would flip and the cells and the tissues would flip to anaerobic metabolism. And that results in a buildup of lactic acid. And the buildup of lactic acid leads to a metabolic acidosis. Now, a lot of times metabolic acidosis blood gases lead to respiratory therapists saying, well, that's a metabolic problem. That's all metabolic. It's not us. But in this case, if we take our job serious and we pursue what we do seriously, then what we'll consider is are we doing our jobs from an external respiration standpoint? And if our jobs are to promote effective oxygenation, not just from an external respiration perspective, but also from a tissue level, then we would speak up in this case. We would say, hey, the lungs are working great. We're getting enough oxygen in, and we're probably getting enough CO2 out. So the problem is not the level of the lungs. The problem is that our patient doesn't have enough hemoglobin to carry enough oxygen out to the tissues. So what do we need to do for this patient? We need to maximize perfusion. We need to increase our level of hemoglobin so that we can get more oxygen to the tissues, so we can get them out of that state of anaerobic metabolism and back into a state of aerobic metabolism. And that'll fix your blood gas. In the meantime, do not recommend giving this patient bicarb. You're like, oh, the bicarb is low, so we need to give them bicarb. No, the problem is not that you don't have enough bicarb in your body or in the patient's body. The problem is that all the bicarb is bound up and occupied by this lactic acid. So you have to get that dealt with. How do you stop the production of lactic acid? You improve tissue oxygenation. And that's what I want you guys to understand. I want you to understand that when you look at a blood gas, and if your blood gas result doesn't give you hemoglobin, then get in the habit of looking at your CBC. Look at your red blood cell count. Look at your white blood cell count. Look at your hemoglobin count. And use that count to assess not just external respiration, but use that count to assess if the job you're doing from an external respiration standpoint is making a difference at the internal respiration standpoint. That's why we breathe, is for optimal internal respiration for cellular metabolism to happen. And so I want you to get this concept. Now, I'm going to flip this and I'm going to go another direction with this, because I've talked a little bit about tissue hypoxia, metabolic acidosis, lactic acidosis, those things. Now I want to flip it and show you the other side of this, okay? So let's get rid of this and let's talk about your chronic hypoxemia patients. Let's talk about your CF patients, your cystic fibrosis patients. Let's talk about your emphysema patients. Let's talk about your patients who live at a state of chronic hypoxemia. Okay? Now we know that when patients live at a state of chronic hypoxemia, that their body compensates for this by creating a state of polycythemia, which is an increase in your red blood cells and an increase in your hemoglobin. So your emphysematic patient or your cystic fibrosis patient, when you look at their blood gas, you may see a P-little-a-O2 that is somewhere around the ballpark of 60. So the partial pressure in arterial blood is 60 millimeters of mercury. And you go, okay, well, they probably live there. So they live in a state of chronic hypoxemia. But do they live in a state of chronic hypoxia? The answer to that is no. Because as the body compensates, they say, okay, if you're not going to bring enough oxygen in, then guess what we're going to do? We're going to increase our carrying capacity for the little bit of oxygen that's being brought in. So what we do is we make an increase in hemoglobin. So your emphysematic patient who comes in with a hemoglobin of 18, we're going to multiply that times 1.34. Let's say they have a saturation of 87%, and that's where they live. And we want to panic about it, but why are we panicking? I'm going to show you in a second. And then we're going to add that to a p-little-a-o-2 of 57. 57 times 0.003. So you look at your emphysematic blood gas, you have a SAT of 87, a p-little-a-o-2 of 57, and some RTs will panic about that. They'll say, wait a second, we got to get that up. We got to get that up to 70 or 80. But you don't, because this person lives at this state. So watch what happens when we do this formula. We have polycythemia, which is an increase in your hemoglobin because the body has compensated for the state of chronic hypoxemia. Now, when you do 18, let me clear this, 18 times 1.34 times 0.87, this gives us 20.9. And we're going to add this to a number that's not even going to matter. 57 times 0.003, and we get 0.17. And we add that back to 20.9, and we get a carrying capacity of 21.07. Now that is a normal carrying capacity. And that tells you that even though this patient would be classified as hypoxemic, this patient is not hypoxic. Even though they have a decreased arterial oxygenation status with a SAT of 87 and a p-little-a-o2 of 57, they are not hypoxic. Their tissues are getting enough oxygen because the body has compensated, created enough hemoglobin to create an adequate carrying capacity. So you need to understand, as this video wraps up, that all patients that are hypoxemic are not hypoxic. And you also need to understand that all patients that are not hypoxemic are not hypoxic. You can have a patient who is not hypoxemic but is hypoxic. Hypoxic refers to tissue oxygenation. Hypoxia refers to the amount of oxygen in arterial circulation. And if you don't have enough hemoglobin to carry the oxygen that's in the blood out to the tissues, then that's the difference maker. Okay? You got to understand this concept. All student respiratory therapists, all future respiratory therapists, all current respiratory therapists, if this is something you've forgotten, then refresh and brush up your skills and start talking to your care team about what's going on from an internal respiration perspective, and stop focusing on just the external respiration side of things. Okay? Hey guys, I hope this makes sense. If it doesn't, put a message up. I'd love to hear from you. I would also like for you to hit that subscribe button, turn the notifications on so that you know when I post a video. I'm just here to try to give you guys a little bit of guidance and a little bit of knowledge and a little bit of support and encouragement as you study this very in-depth and challenging field of respiratory therapy. Best wishes.